Thank you so much for the invitation to present at SAGES. So I'm going to go over retained and ingested foreign bodies. And if you're a pediatric surgeon, I mean, this is pretty much everything you do all day long. But maybe I can show you a few new things that are coming onto the block and that we can discuss here. So I have no disclosures, nothing regarding this presentation, and actually nothing regarding anything else, so period, which is good and bad, so I can say whatever I want to. We're going to talk a little bit about the risks of foreign body ingestion, the types of foreign body that are ingested, the difficult ones, the red flags that you should be aware of, and the management of button batteries in particular, and magnets, because those are probably the ones that are the most troublesome, and then other foreign bodies such as bezoars or plants and other things, toxic substances, which you can encounter as well. And a lot of us don't, have those algorithms ingrained so much. So I'm going to start with a recent case that came in, I think, in the beginning of January. And this is a 6-month-old that presents to her primary care provider with a cough and mainly a cough. So they do a COVID test, of course. Now it's 2023, but the last 3 years, we've done COVID tests, and it's positive. And she just doesn't get better, and she coughs and coughs, and they diagnose her with long COVID now because she's been doing this for like months. And so then she gets worse and worse and worse. She has breathing problems, and she has decreased appetite, and she's now losing weight. And actually, somebody out there now gets in an emergency room, gets a chest X-ray, and she's now in really bad shape. And they send her to us, and she's got trouble breathing. She gets intubated, gets a CT scan, and this is the SCOUT. Unfortunately, I don't have the outside X-ray, but it's pretty much this. And what you see is, of course, this foreign body very high up in the neck. So we did the CT scan, and this is what we found. So you have that foreign body that has that typical ring. So it's a button battery, one of those 3-volt large button batteries, lodged in the neck. And you can see the intubation there. So we took her to the operating room, and I endoscoped her from above, took out the button battery, which was a lot of trouble. This is what we saw from above. I didn't see any lumen, and when I advanced the scope, the 5mm scope, I only saw the endoscopic tube, like the ET tube. So what do you do now? You don't have a lumen. So what we did is we did a gastrostomy at that time, and I scoped her from below, and then I would reach the neck and just see this sort of cloud of granulation tissue. So I blindly advanced a wire, and luckily it came out the nose. So so we put a NG tube over the wire. You see that there, and then we finished the procedure with a GJ tubes to feed her enterally. So a few days later, we get another CT scan, and what you see is this TEF. Basically, it's like an H-type fistula, or an N-type fistula, but it's the reverse, right? You actually usually you go from trachea to esophagus downwards, and now you're right the other way around. So that explains the endoscopy. So we actually tried this using a sponge. So I like using endosponges a lot. We talked about that 2 days ago. And this is the first change. And I thought, there's so much granulation tissue, maybe I can just grow it to seal it off. Didn't work. So after doing like 2 or 3 sponge changes and still having that, we went in, and I basically did what a pediatric surgeon does in an H-type fistula from a collar incision. Luckily, it was on the left side, on the right side, so I could go in and fix that fistula. Put a little flap through, like a sternocleidomastoid muscle flap in there, and you can see that dark area. That's one of the sutures, but it's actually closed quite nicely, and this is what you see. This is the typical picture after like an endosponge. It grows the tissue back. So she's still in the hospital, and we got some trouble with the recurrent laryngeal nerves, because you can have that just from the inflammation, and of course also from operating. So types of foreign body, what are there? Well, anything a kid can get their hands on. So this is actually my daughter 20 years ago. She's actually in the audience right now. She's a medical student. So, and she's playing around with a toy. So this is a high-risk procedure, high-risk activity. So if you have foreign bodies, you always should go through, are they radiolucent? Are they radiopaque? If they're radiopaque, you can get a chest x-ray. If they're radiolucent, like a Lego block or something, you have to rely on indirect signs, like, are there atelectasis in the lung or something like that. They can be sharp and blunt. Obviously, sharp is more trouble. It can be large, small. So generally, we say over 6 centimeters long or 2 centimeters in diameter doesn't pass, but that's for adults. So in kids, in small kids, that's different, and every kid is different. So you should just make sure that you know, is it a big or a large, and what's the configuration of the foreign body, and then are they toxic or not? Obviously, toxic ones are more trouble. So risk factors: small children, anybody between 6 months and 3 months, those are the ones that get their hands on this and put things in the mouth or in the oral phase, and so mental and psychosocial retardation is one of the large risk factors, as is ADHD. So we see a lot of these kids. They're bouncing off the walls all the day. They're on Ritalin, and they put things into their mouth, whatever they get their hands on. Malformations of the GI tract. So our clientele that has esophageal atresia, I don't think they ingest more, but obviously if they ingest it, there's a reason why it can get stuck. And if you've operated on a kid on their GI tract, you have a high index of suspicion, it can get stuck there. So what are problematic red flag foreign bodies? So button batteries, way up on the list. Large and long objects, we already went over that. This is something I learned from preparing the talk. So what's in the diapers? The super absorbent polymers, they can produce large bezoars, as can hair, of course. If you have trichotillomania, you can have that. Magnets. So I like using magnets for esophageal and anastomoses and acupuncture and all kinds of stuff, but these can be really tough and really difficult. So magnets, especially if you have more than one magnet or a magnet and a metal object, be very aware of that, can give you trouble. Sharp objects, obviously, and lead-based objects, toxic plant material, all that kind of stuff. So the one thing I want you to take along, if you don't already know this, it needs to be ingrained. An esophageal button battery needs to be removed immediately. Immediately. Don't go, via a start. Don't get $2,000. Don't do all that thing. Just go to the operating room. Immediately take it out. If they are in the stomach, you can monitor, or distal, you can monitor them. We typically, if they don't pass within 24 to 48 hours, we take them out. And if they're distal, we just monitor them. We don't want them to, we want to have them come out. And you have to, like our case showed, you have to have a high index of suspicion. So I don't have to go into this because you can read these very nice guidelines that are NASPGHAN, ESPGHAN, the Europeans got together with North Americans, and it's very clear what you have to do. Essentially, the algorithm goes, is it in the esophagus? You go right to the operating room. If it's been there for a very short time, you can take it out endoscopically usually, and if it's been there a long time, have everything available. Have you be prepared to do a laparotomy, be prepared to do a thoracotomy. You can have a fistula between the esophagus and the aorta, and those are obviously a lot of high-risk morbidity, mortality cases. If they're distal, we typically follow them by x-rays, or in recent times with a metal detector. We want them to be out. We are not happy with a patient. We don't send them home and say, oh, it's going to poop it out. We want to see that either in the poop or, somehow we want to see the kid without the foreign body or the button battery in there. So this is something really new. Who uses honey for button batteries? Who has protocol? So all of you do it. We do. This is something that is super interesting. So somebody put like button batteries and ham and pig esophagi and goat esophagi and or sheep, I think they were. And actually, there's like 4 publications out, but they've already gone into the guidelines. So we're supposed to do this. You're supposed to do this. If you don't, some lawyer can say, but it's in the guidelines, you know. And so we adopted it. We have in our emergency room, we have medicinal honey, and there's like guideline. This doesn't happen very often, but if they come in, they get 10 milliliters of honey every 5 minutes if they're over 1 year of age. Otherwise, they get sucralfate if they're younger, because honey can have botulism in it, so we don't give it to young kids. So we do that, and we don't delay. That should not delay your going into the operating room. And talk to your anesthesiologist, because we were concerned they would say, oh, now they're not NPO. And don't, it doesn't matter, and our anesthesiologists are okay with it. So we just give it. Other thing is magnets. So magnets, if you're simultaneously swallowing magnets, nothing should happen because they just go through. But if you swallow them like piece after piece, then they can make fistulas and they can click together. So really the thing is it a single magnet, or are there multiple magnets swallowed at different times? And if there are, that's trouble. That needs to be watched. And if they're not progressing, meaning that don't go through, they don't change then you need to take them out. Either endoscopically, we usually go in endoscopically, try it. If it is like one is in the colon and one is in the stomach and we can't move it, then we go in and do a laparotomy or a laparoscopy. There's one magnet. Don't forget, don't just send them home. Tell them, don't give this kid any other magnets, right? Because you don't want them to come in the next day with a second magnet and, you just saw this kid. So tell them you need to make sure that there's no metal objects around this kid, that, the kid does not get into trouble with the second one. Bezoars, every pediatric surgeon has these pictures. It's hair, again, like I learned, these polymers, these super absorbent polymers can do it. Basically you have to take them out. People have used like Nair, but I don't do that. I don't put Nair in kids. It's very off-label. So if you do that, and you want to solve it, not a good idea. Toxic substances, so many. So, as a pediatric surgeon, I'm a simple thinking guy. I don't know all the plants and everything. Just call your poison hotline. They will help you. They're there 24 hours. They will know, and give them as much information as possible. So lead paint is a big one. These tabs from dishwashers are a lot of trouble. So we see that. They like nibbling on them, or, they look like candy. And obviously oven cleaner and that sort of thing. But that, is usually something you manage with your gastroenterologist. So kids frequently ingest foreign bodies. You need to know about this. You need to have your engrams in the back of your head. Most of these pass without problems. Button batteries and magnets, 2 magnets or a magnet and a piece of metal that can be magnetic, lots of trouble. Beware of that. Always, don't send those kids home. And if the button battery is in the esophagus, you have to take it out immediately, as fast as possible. And think about the honey thing. You might want to introduce this. And we're actually running a prospective study. I mean, the problem is, how often do you have this, once a day? We should all get together to pool our data and see if it really makes a difference. Thank you so much.